Antimicrobial dressings. Systemic management of known comorbidities and wound bed preparation are necessary to ready the wound bed for healing. Sibbald et al. First described the time model for wound bed preparation, which involves removal of devitalized tissue, reduction of infection/inflammation, moisture management, and prevention of edge rolling or epibole. The use of antimicrobial wound care products has received a great deal of scrutiny, with some literature suggesting there is no evidence for the use of these products in wound care. However, it is important to understand that the selection of an antimicrobial agent is not meant to bring about wound healing. An antimicrobial dressing may be selected for treatment or palliation in order to reduce the bacterial burden of a wound, decrease pain associated with care, diminish wound odor, potentially interrupt bacteria biofilms. Further, an important potential benefit of antimicrobial dressings is to reduce the use of systemic antibiotic therapy that is prone to bacterial resistance. The overuse and abuse of antibiotics reflects the lack of practitioner knowledge surrounding proper management of complex chronic wounds. Biofilm. Some bacteria and fungi have the capability of inducing a radical change in their phenotype following attachment to the wound surface. The bacteria irreversibly attached to the wound surface become mitotically senescent within the biofilm base, and have enhanced resistance to the host's antibodies as well as innate phagocytosis. The development of this bacterial biofilm results in a chronic state of inflammation for the host, which cannot be removed with the routine use of wound cleansing or antibiotics. NB. The minimum concentrations of many antibiotics needed to eliminate a biofilm may be thousands of times the standard dose and exceeds the maximum prescription dose available. Both sharp and ultrasonic debridement are often indicated on a twice-weekly basis, given the speed at which the biofilm may fragment and resurface the wound bed within 48 hours. The decision and selection of topical antimicrobial wound dressings is multifactorial, with asking these questions. How can I dress this wound so as to manage the exudate or moisture level, decrease the frequency of changes, decrease the pain of the patient, decrease the risk of trauma to the wound bed, and adequately pack the dead space? Is an antimicrobial necessary? Can my patient afford these dressings after discharge? In some cases, the antimicrobial selected is related to its known effect against certain pathogens. In other cases, selection is more related to the dressing construct and delivery method of the agent into the wound, and how it manages the other considerations listed above. The decision may be made based on the clinician's personal experience with a particular agent in the specific wound type that is being assessed. Much of wound care selection is a mixture of science and art. According to Gethin, dressings should be selected per the specificity and efficacy of the agent, potential cytotoxicity to human cells, effect on resistant bacterial strains, allergenicity, cofactors of the wound based on size and exudate, and total bacterial load. Silver, in ionic or nanocrystalline form, has for many years been used as an antimicrobial agent. Silver dressings may be the most popular selection for the reduction of wound bioburden. The first reports of silver being used as an antimicrobial agent were in the days of Hippocrates, until it lost favor with the advent of antibiotics during World War II. One of the major reasons silver is so readily used is because of the wide variety of dressing delivery types that are available. Silver is provided in amorphous hydrogels, sheet hydrogels, alginates, hydrofibers, foams, silicones, contact layers, wound powders, ointments, negative pressure foams, and irrigations in the form of silver nitrate solutions. The document states that the metallic form of silver is unreactive and does not have a bactericidal effect but must ionize to its active form, usually through contact with wound exudate. The benefit of silver is its ability to affect multiple sites within the bacterial cells, such as binding to bacterial cell membranes, interfering with binding proteins and energy production within the cell, decreasing enzyme function, and providing DNA and RNA transcription inhibition. Additionally, silver may increase the sensitivity of a biofilm to antibiotics as well as alter its adhesion to the wound bed. The use of silver is recommended for a limited time due to potential apoptosis of keratinocytes, fibroblasts, and leukocytes. Silver can become cytotoxic to host cells if the dressing delivers large quantities of the ion to the wound and is used over extended periods of time. Therefore, silver dressings should be discontinued when signs of inflammation and critical colonization have resolved. Symptoms indicative of resolution include improved color and quality of granulation tissue, disappearance of peri-wound hyperemia, reduction in surrounding erythema, absence of purulence, decrease in pain, and decrease in purulent exudate. Silver safety. A child's skin is at risk for absorption of topical products leading to systemic toxicity. Wang et al. Showed that silver toxicity was a concern when examining pediatric burn patients and the use of nanocrystalline silver dressings. Not only were serum levels elevated, but they were closely proportional to the surface area of the wounds treated. However, more research is necessary to determine the amount, length of use, and type of silver dressings that may or may not be safe for the pediatric population. Silver dressings are not advised for neonates, and the usage of such products in the pediatric population is limited to no more than 2 weeks. Iodine also has the ability to lower the microbiological load in chronic wounds. Clinically, it is mainly used in one of two formats. A. As povidone iodine and B. As cadexamer iodine, a three-dimensional starch lattice containing 0.9% iodine. Cadexamer iodine has good absorptive properties. 1 g of cadexamer iodine can absorb up to 7 milliliters of fluid. As fluid is absorbed, iodine is slowly released, reducing the bacterial load and also debriding the wound of debris. Caution is required in patients with a thyroid disease owing to possible systemic uptake of iodine. Metronidazole gel is often used for the control of odor caused by anaerobic bacteria. This is particularly useful in the management of fungating malignant wounds. It may be used alone or as an adjunct to other dressings. Honey. The use of medicinal honey has increased in popularity over the last several years. However, it is by no means the new kid on the block. Medical-grade honey has two general sources. Leptospermum scoparium, manuka, which is derived from tea plants, and Leptospermum polygallifolium, which is jelly bush honey. Both forms have specific qualities related to their processing that affect the bacterial count, pH, enzyme activity, and overall benefit in wound care. Honey is used for its many capabilities, for example, antimicrobial action, debridement action, anti-inflammatory properties, moist wound maintenance, low pH, and exudate absorption. One of the major benefits of honey is the ability to both provide bioburden control and enhance debridement at the same time. A study by Gethin and Kauman showed that honey was more effective at desloughing wounds with greater than 50% necrotic tissue than standard hydrogel, leading to statistically significant faster healing rates and decreased time to epithelialization. Moreover, the authors state that while sharp and biologic debridement may be faster, honey may be superior to the autolytic or enzymatic debridement seen with hydrogel, collagenase, or cadexamer iodine. Wound types and appropriate treatment. If too dry, use a hydrogel to hydrate. Dry eschar may also benefit from enzymatic debridement ointments such as collagenase. If the wound has minimal drainage, a hydrocolloid will keep it just right. If there is heavy drainage, absorb excess fluid using material like alginate, hydrofibers, cellulose, foam, ceramic fiber, or negative pressure wound therapy. If the surrounding skin shows maceration, use zinc oxide, protective films, or a negative pressure wound therapy. If the wound is infected and there is a lot of sloughs, which cannot be mechanically debrided, then a chemical debridement can be done with collagenase-based products. If the bioburden needs to be controlled, a silver-based or iodine-based product should be used. If the wound has an excessive odor, topical metronidazole or activated charcoal dressing material will help. If the wound has healthy granulation tissue and needs to have faster healing and epithelialization, hydrocolloid, foams, collagen, or silver collagen will help. If the wound is superficial, occlusive semi-occlusive dressings help to heal. Polymeric membrane dressings also are good to treat superficial abrasions. Inappropriate use of dressings may lead to unwanted effects. Examples: maceration of the skin surrounding a wound may occur if a dressing with a low absorptive capacity is used on a heavily exuding wound. Conversely, use of a highly absorptive dressing on a dry wound may lead to disruption of healthy tissue on the wound surface and cause pain when removed. Tapes used to keep dressings in place are common causes of allergy. Conclusion: the process of wound healing is not static. It requires an appropriate environment at each stage of the healing process, and a reasonable approach to the selection of dressing for certain types of wounds should be clarified for clinical professionals. Until dissemination of new knowledge occurs within the healthcare community, the inappropriate use of dressings such as wet-to-dry gauze, which are known to inhibit wound healing, increase the costs of care, and increase pain, is still prescribed. Moreover, the lack of wound care knowledge by the non-wound clinician may also lead to the inappropriate selection and use of antimicrobial dressings, when in fact they are not indicated. There are more than 3,000 different wound dressings to help address all the different aspects of wound care. While a wound care specialist can determine the appropriate dressing for each wound, having a thorough understanding of the different types of dressings and when to use them can be crucial in promoting wound healing and preventing complications. The specific selection of modern wound dressings for different wounds should be based on the particular conditions, such as the patient's primary disease, the characteristics of the dressing, and especially the physiological mechanisms of wounds. An ideal dressing is expected to possess the capacity of moisture balance, promote oxygen exchange, isolate proteases, stimulate growth factors, prevent infection, facilitate autolytic debridement, and promote the production of granulation tissue and reepithelialization. However, currently, there are no dressings that can achieve all these functions.